P.D. Patil, distinguished faculty, distinguished speakers who are going to speak or have already spoken, Dr. Jindal, an old friend and colleague, Dr. Patil, also an old friend and colleague. Ladies and gentlemen, thank you for inviting me here and thank you for the honor you've conferred upon me. Now, you are all in a Congress of Respiratory Medicine and Critical Care, branches to which I am partial, frankly. I'm not going to therefore go into the technicality of this. I'm going to speak on certain aspects of general medicine. Aspects which I feel have sometimes been ignored or forgotten. Aspects which are important in medicine, like, for example, clinical judgment, the art of medicine, the importance or the unimportance or the valued importance of evidence care in medicine. I would like to speak on that also. I would like to speak on the pockmarks that blot the face of medicine today. That's important. That's the other side of medicine. Perhaps a little on the medical ethics. As it comes into my head, it's not a prepared speech. I'm just going to speak straight on. I think you all know the great advances of modern medicine, contributed to mainly by science and technology. I don't need to detail the great advances which might have seemed miraculous, for example, 70 or 80 years ago. But there is a strange paradox. I don't know how many of you will agree, many of you will. There is certainly a certain amount of animosity and antagonism and a certain amount of frustration amongst the people who are not medical. The contrast is doubly striking. For in my very young days, the medical profession was supposed to be the most respected profession of all. And the doctor was one of the most respected people in society. He could do no wrong. He was almost treated like a god in many places. Even when I was a houseman and resident and registrar at a KM hospital, he could do no wrong. And that was at a time when there was very little science comparatively, very little advances in medicine as you see them today. And today, when you see such great advances in medicine, you find that the medical profession is not as sound in its position as it used to be. And the image of the medical practitioner has certainly gone down to a significant extent. Look at for example, the burning of hospitals, beating up of residents and even consultants, blaming our consultants whenever there is a death in the hospital, very often wrongly and rightly. You could see that for yourself. Now, why is this so? That is the question. Have you ever asked yourself that? I think part of the reason, a good bit of the reason, is because I feel that medicine has slightly strayed in some ways from its path. It has been submerged. This art of medicine has been submerged by the science, technology, and its hubris. Therefore, its raison d'etre, that is its reason for being, is being questioned. The physician, some or the other, does not relate to his patient as he should. In modern days, he relates very often to the machine, to sophisticated gadgetry, than to his patient. The machine becomes actually the pathway through which he deals with the patient. And even the patient is made to be more dealing with the gadgetry. The patient will come and say, I want MRI, I want this, I want that, which never used to happen at that time. The doctor would say what the patient needed. What happens because of that? Therefore, the doctor-patient relationship, the bond between the doctor and the patient is snapped or is eroded. And that is bad, obviously, both for the doctor and the patient. What happens is that today the doctor does not deal with an individual patient or the patient as a distinct individual. He is more concerned with disordered functions of various organ systems, so that the patient who houses these organs is really forgotten, is pushed into the back. There's no doubt that science and technology are important, but I notice particularly even in the postgraduates, even in the intensive care unit which I work, that the young intensivists are more concerned with the technology and science underlying various aspects of modern medicine. They seem to forget that medicine is learned at the bedside, by touching the patient, by feeling the patient, by talking to the patient, by listening to the patient. Of course, science and technology are important, very important. I don't deny their importance. It is they that have been responsible for catapulting modern medicine into the present age and will continue to do so for centuries to come. But I want particularly the younger people here, the students if they are here, to realize that there is more to medicine than science and technology. Technology cannot take a good history. Technology cannot perform a meticulous, careful physical examination. Science and technology cannot assuage the anguish of patients who are dreadfully ill in the intensive care unit, nor can they help the anxiety that is felt by the relatives and the near and dear ones of persons who are dreadfully ill. These belong to the art of medicine. And what is the art of medicine? It's difficult to define the art of medicine in words. It has no quantified elements, as many sciences have. It has no physical attributes. It is not mathematical. It doesn't consist of figures, diagrams, algorithms. No. The art of medicine really is something related to features of both the heart and the mind, which combined in the healing process, which combined to help the patient get well and heal. And it's not just the medication that is there important, it is important, it's much more than that. Art of medicine, of course, requires expertise, you can't deny that. But it's not just expertise. It is just not looking at the physical problems afflicting the patient. The art of medicine is also concerned with the mind. because the mind affects the body to a great extent. And it is very important that the physician realizes that. It is an art which is, I'm afraid, forgotten now, or almost forgotten. It's certainly hidden behind the hubris of science and technology. And it is an art which should be remembered and which should really not be lost. When I speak of this, and I often do this to so many of my young students, they often ask me, tell me then, what exactly do you mean by that? I said, in practical terms, it's very simple. History taking, that's an art. It is an art which can be never perfected, however great a physician you may be, and however many years you may live. For the simple reason that the same disease presents itself in different ways in different individuals. Each patient, therefore, is indeed unique as an individual. And if the same disease presents itself in different ways, you can imagine the number of ways in which a history can be told for the same disease. The response of a patient to a disease is often unique. Not necessarily, certainly not the same. It just does not depend upon the disease process. It depends upon the way he reacts to it. It depends upon the abnormalities that the disease does to his physiology. It depends on the adaptation of that body to these changes. It depends on his genes, his constitution, his geography, where he is, where he is residing, his constitution, as I said, his physical and mental strength. Depends on so many other protean factors. That is why you can never master the art of history taking. I have difficult patients referred to me from all over the country. I'm talking about medicine, just not respiratory medicine. Believe you me, many times when I'm stumped as to finding out what the blazes is the matter with him, I go back to the patient and talk to him. The history. And not uncommonly, a chance remark made that by the patient. A remark literally made off the cuff, which he thinks unimportant at all, strikes a bell in the doctor's mind and tells you, perhaps I must follow this avenue. And they ask then, what do you mean by art of history today? I'm just recounting questions and answers I've been answering for quite some time to students. What do you mean by, what is the art in history? The first thing is listening to your patient. And how many doctors today listen to their patients? Patiently, I ask you. There's no time for them to listen. Listening to the patient is extremely important. You listen, when you listen not only to what his complaints are, you gauge the patient. What is he like? What sort of an individual has come to me? Can I figure out what his mental state is like? And after listening to the patient, we have to question him, talk to him. And there are some patients, as you know, who talk a dime to a dozen, and you are lost in the verbiage that he gives you, and to pick up the grain from the chaff, from the dust and from the dirt is very difficult. And there are some patients who underplay their symptoms. So they may be having a heart attack, but they say, I'm fine, just a little discomfort here. So it requires a lot of patience and a lot of listening and a lot of questioning before you can have worthwhile history. And a history is the first step to diagnosis, and the diagnosis the single most important thing, the second most important thing, and the third most important thing in medicine. For you can look up the treatment in 100 places, and maybe you might not treat somebody as well as somebody who has had a lot of experience, but you can still do reasonably well. But nobody is going to teach you diagnosis. It is the patient who will ultimately teach you the diagnosis. And one must remember that there is a mind-body combination. And one must remember, and doctors forget, that very often the mind is the origin of a number of symptoms which mimic disease. And if you don't realize that, you're asking for trouble. You will be asking the patient to do unnecessary tests, unnecessary investigation. And also you will help the patient to go from one doctor to the other. I would love to give you some examples of that, but I don't think time will allow me to do so. I wish I could really, but no, if I have time and you ask me, I'll give you one or two examples which are classic examples as far as I can see. But anyway, what after the history? If you have a bad history, if you have a patient who can't give a history, a patient who's unconscious and comatose, who's not got anybody around him to tell you what has happened to him, it's a difficult problem, very difficult problem. Then comes physical examination. That is an art and a science. The art lies in eliciting the right physical findings. The science lies in interpreting that finding. So it's an art and a science combined. It is therefore very important for young students particularly to cultivate the faculty of seeing things properly. None are so blind as those who have eyes and yet not see. The ability to feel, to touch, to smell. The ability to process all that you have sensed within your brain, within your mind. The ability to recall past experiences to a present situation, and then to judge and perhaps come to a reasonable diagnosis. You can only do that, if you're trained in the art and science of taking a good history and doing a good physical examination. If you are really trained to do so, you almost do this systematically, with discipline, and almost unconsciously. You have followed a routine which almost becomes a matter of fact, an everyday routine in your life. I must quote William Osler here, my great hero, if I may say so. He says, learn to see, learn to hear, learn to smell, and know that by experience and repetition only will you be perfect. He continues, medicine is learned at the bedside, not in a classroom, and not in a lecture hall, not even from a book. Learn to see, then you may read, then you may judge, and then you can decide. I think these are very important words which are forgotten in today's world, where the doctor more often than not relies on machines and gadgetries and forgets to take a good history and forgets to do a very good physical examination. I must tell you, physical examination is so important. Which machine is going to tell a diagnose as a patient walks towards you that, oh, he's got myasthenia? No. Or which machine is going to tell you that this man has a myotonia congenita as he walks in and as you start to look at him? Or, for example, a first mild third nerve palsy, a slight drooping of the eye for whatever reason. Which machine is going to detect small purpuric spots on the legs of a young boy or a young girl who's running high fever, telling you, oh my God, this is dangerous, he might be having meningitis? Which machine will be able to pick up a pleural rub, a pericardial rub? I ask you. So you see, I can quote many other physical findings, which no machine or gadget can immediately recognize, and on which your diagnosis is made, so that if you made a diagnosis, you would prevent doing unnecessary, expensive tests, detriment to the patient. So if you were to ask me, I could go on, but I must try and touch a few other topics. How would I define the art of medicine? I've been long in thought over that. I told you it's difficult to define. Perhaps the best definition I would give to the art of medicine is the artful application of its science to the holistic care of a human being. That perhaps would be my best definition. And let me just give you in practice what it means, what I mean, for example. First of all, the art of medicine remains when science has reached a dead end. When you're looking after a patient who's terminally ill, the art of medicine comes into play then. It's so important. Well, let me just give you a few examples. The art of medicine, I think, lies in hearing an unspoken word or sentence in a patient's history which you suggest, or in recognizing certain physical findings which give you an idea of the diagnosis or the prognosis and even also of the treatment. The art of medicine lies in sifting the evidence in front of you and giving an appropriate answer to a question. An appropriate answer amongst many possible answers to a relevant question. The art of medicine, I think, and the science will often scoff at this, but I don't, sometimes is in the intuitive feel of what is happening to the patient, what is to be done to a patient. You can't explain it clearly on scientific terms, but it is there. The art of medicine, I think, lies in judging a patient holistically, not just the body, but also the mind. It lies in not compartmentalizing a patient into several disordered organ systems, but looking at him as a whole. I think, ladies and gentlemen, if I can sum it very easily, the art of medicine is not just treating, not even just curing, but healing. But I must admit that it is only when art and science join hands that healing can really occur. It is only then that a doctor can engage the unique personality of a human being so that a sick individual is just not a disease to be treated and cured. If you look at the patient holistically, and that's clinical judgment, and I think that should be relevant particularly to people who are practicing critical care medicine. A doctor must be a judge, for after all, a great doctor has said, the medicine is an art of probability based on incomplete evidence, which is so in so many instances, as you all very well know. But judgment is difficult, and of course we all make mistakes. You cannot deny that. Everyone in this world has made mistakes at some time or the other. I have made mine, which I sometimes see retrospectively, if not at that point in time. But I am of the opinion, that good judgment is there from the beginning in a doctor. I suggest he's almost born with it, perhaps. Certainly you cannot equate good judgment with knowledge, intelligence. Certainly not. That I have learnt over the years, seeing so many people working with me. But can you improve then on good clinical judgment? Perhaps yes, you could. You could, with a lot of experience, cleverly digested experience. But my feeling is the real way for those of you who want to improve your judgment in medicine is to look at other fields of human endeavor and be interested in them. May it be art, may it be music, may it be philosophy, may it be literature, may it be poetry, may it be religion. I feel personally that a physician who looks at the world with a broader perspective, looks at man in all his perspectives, different perspectives, somehow or the other, intuitively almost, is a better physician. And of course, all of you who are intensivists have confronted sudden, life-threatening emergencies. I feel that to cope with a life-threatening emergency is not just your knowledge, your intelligence, your experience even, and skill also, is enough. It requires real good clinical judgment. Clinical judgment, therefore, doesn't just comprise all these entities. It does, but it has some additional, rather indefinable quality. It is a quality which has hope, charity, compassion, faith. It is a quality which understands human nature. That's why I said a broader perspective of man is so important. It is a quality which enables the intensivist to reach down to a very sick individual and uplift him, uplift his shattered morale. It is a quality which enables him in a crisis to know what to say, what not to say, what to do and what not to do, when to wait and watch, and when to treat immediately, vigorously. When to fight death or give in to it. When to press for a cure or just rest content with kind words and palliative relief. So that an intensivist, or for that matter, a physician, after all, intensivist is basically a physician who knows general medicine. So that a physician, therefore, who with his good perceptual ability, with his learning, with his experience, also has this remarkable faculty of good clinical judgment. He is indeed blessed by the gods, if you ask me. because he has an attribute which no machine can duplicate or no science can invent. That is the rub, ladies and gentlemen. I would now like to spend a few sentences on the importance of evidence-based medicine. Of course, evidence-based medicine is important, particularly to the intensivists. Who doesn't know that? You have to read it, you have to know it, you have to understand it. But I think, particularly for the young people who are so keen on looking at the net and looking at all the new guidelines and new evidences that come forth from these guidelines, evidence-based medicine is not sacrosanct, because if it were, it wouldn't change. And as you know, evidence always changes. So please remember that. Look at it in a balanced view. It is important, but not infallible. It is inclusive, but yet, again, not to all. It applies to many, but there are exceptions, and important exceptions. There are many other things in medicine when you are treating a sick individual. The social aspects, the economical aspects, the psychological aspects, the religious aspects. The person who has other problems, other medical problems, which are not covered by your guidelines, all these need to be taken into consideration. You must therefore look at it in a very balanced fashion before you apply evidence-based medicine and the results of evidence-based medicine to your particular patient. Please remember that. I need to also express my deep anguish at the sharp deterioration in the ethics of medicine. I can only speak about the city of Bombay. It is heart-rending to see how the ethics of medicine has gone down the drain. I need to say, what is ethics of medicine? Have you ever thought of what ethics is? Can you define the ethics of medicine? I would define it as the moral obligations that govern the practice of medicine. So there is a right and a wrong. When you use the word moral right and wrong, there is obviously good and bad, and it's the duty of the physician to follow the right path and not the wrong path. It's not always easy for several reasons which I will not go into. But the roots of ethical medicine are rooted, really speaking, in a particular community or a country, depending upon its social features, its philosophy, its religion, its behavior. That's why the same ethics need not apply to different parts of the world. That's the reason. So it's important to really realize. And as you know, the single most important feature of good ethics is beneficence. You know that, I'm sure all of you, doing good to the patient. Just not physically, but also emotionally. You all know that. And its counterpart, non-malfeasance, which means that you should do no harm. And that is so important in the present day. In fact, if you consider evidence-based medicine, there should also be a great deal of evidence to show and prove that whatever drug you are going to introduce not only does good, but does not do harm. That is so important. Once upon a time, The practice of medicine was parental. It was the doctor acted like a parent. So you do this, I'm telling you do this. Now it's not so. It's patient-centered medicine. Patient autonomy, as you will. Patient autonomy is important. But how many of you as intensivists have encountered a situation where the principle of beneficence and the principle of autonomy come into straight antagonism? Patient autonomy means you will do what the patient wants you to do. You will abide by what the patient says. When he says, I don't want this, I don't want this investigation, I don't want this test, I don't want this treatment. What do you do then? It's all right in a court case. Patient autonomy really matters. This is my view, but if you like, go back, go home, ask your other doctors, take a second, third, fourth opinion and see what you want. But what happens in a real, acute, life-threatening emergency? Therein you must remember that autonomous decisions by a patient which is contrary to a treating physician have to be reasonably logical and have to be taken after serious thought and consideration. Otherwise they cease to be autonomous. Autonomous decision in life-threatening emergencies can be distorted by panic, by anxiety, by hatred of doctors and nurses and hospitals and instruments, etc. Would you countenance such an autonomy? It's not an autonomous decision. So when there is a life-threatening emergency, beneficence, in my opinion, undoubtedly should be given preference to autonomy. I thought I should mention that. A very important aspect of medical ethics is communication. You must communicate with the patient, ladies and gentlemen, doctors, intensivists, and whoever you are. You must communicate with the patient. You must tell him what is happening, why you are doing this, why you are not doing this. Then you make an ally of your patient. He becomes your ally in treating the disease. You must, of course, communicate with the relatives, unless you want a suit on your hands. My time is more spent in communicating with the relatives and communicating with the patients, because they can be so bloody difficult and sometimes so frustrating. You do your best to explain to them, but they will not listen. They tell you something stupid like this is a very good hospital, this is a very good unit, there are such nice doctors, why is he not getting well? How can I answer that question? I've explained everything to you, why he's not getting well. Anyway, of course, to be ethical, you have to be honest. You have to have integrity. If medical ethics is really a branch of general ethics, it's not a total separate entity in itself. Finally, have I time, or have I exceeded myself? Can I go on?
You have time.
I just want to tell you the pockmarks, as I told you, on the face of medicine today. It is the mechanization of medicine, strangely enough. The mechanization of medicine and science which has brought in its wake certain great disadvantages. One of them, as I told you, is the lack of humanism, the lack of humanity, the lack of, therefore, trust between the doctor and the patient, and the disruption of the doctor-patient relationship, doctor-patient binding together. That is due to the mechanization of medicine. Doctor is so concerned with machines and gadgetry that the patient holistically is lost sight of. Talking again critically, this is what happens sometimes, you see, in a critical care. The patient very ill. the poor intensivist who is looking after him is doing his best. And the relative says, no, you say he's got a fast heart, I want a cardiologist. Okay, cardiologist. He has a little bit of headache, call the neurologist. His hemoglobin has not come up from 10 grams so far, call the hematologist. He's coughing last night, call the respiratory tract. This is what God goes on. After all, too many cooks, as I say, spoil the pot. And believe you me, when they asked me to come, I said, how many people? Why do you want me now to look after? This is when I asked, wait, what's going on? You won't believe. Nobody knows how it all started, how it has progressed, and how is that to become like this. Because each one is looking at the small field of gas. Respiratory man is looking at his lungs. Heart man is looking at the heart. Kidney man is saying his urine output is low, don't do this. Heart man is saying you must give him more fluid, otherwise this will happen. The poor fellow is torn between 10 people and dies. That's how it happens. I've seen it. So it's a point to remember, do not compartmentalize this, please. But you're forced, your poor intensivist is in a fix. The relative who's a VIP said, I want the heart fellow. Why haven't you called the heart man as such? He's got a tachycardia. Can't you see? Rate is 130 per minute. This is how it has happened. So it's a remarkable, unfortunate thing in medicine. What is the other pockmark in medicine? Commercialization of medicine. When a doctor puts money before the patient, it's a shame. And it is the standard thing in the city of Bombay today. That's the sad part. Commercialization of medicine leads to malpractice. It leads to cut practice, which is disgraceful. And I have sort of tried my very best to say, is there any way of countering this? I find it's impossible to do that, really. I find it impossible to do that. So that is the greatest blot today on medicine. And the next blot is the expense. It's crippling expense. In a city like Bombay, you would spend 1 crore of rupees within 15-20 days on a very serious illness. Maybe it's not so here, maybe it's not so in other places. Maybe it's not so in government hospitals, I know. But it can cripple a whole family. And finally, the institutionalization of medicine, which, for example, in the city of Bombay, within a radius of 1.5 kilometers, there are 5 MRI machines. Each hospital competes with the other to be best equipped. What happens? I'm talking particularly in radiology and the MRI machine, which is very, very costly. The CEO said, what the hell, what are you doing? I mean, I'm running at a great loss, and they will ask me, what is happening? You better do better. What does he do? If he's a full-time person, he trembles and he might be asked to go. So he feeds the patients to the machine. Machines become fodder, or rather, patients become fodder to the machine. So that's how it is. So there is, in fact, ladies and gentlemen, a real downgrading of all good values that we see, not just in medicine, but in almost all fields of human endeavor. I've seen that as I've grown up. And one person therefore asked me, sir, if there is a sea of filth around you, how do you expect the medical profession to be? Question. Can you answer that? I couldn't. I said it has to be, because it's an altruistic profession. It is supposed to be a profession where you have the patient first and everything else next. So this is how bad the situation. Forgive me, I have to speak of something which you will not normally hear. Has any one of you read Ivan Illich? has written a remarkable book called Medical Nemesis, the first edition. It was compulsory reading for every registrar of mine during the 30 or 35 years that I spent teaching at the JJ Hospital. His second edition is now called Limits to Medicine. That's a very nice book indeed. He's not a professor of medicine, he's a professor of sociology in Mexico, a very renowned professor. And he starts with an overwhelming statement in his book that modern medicine has not done much good to man. In fact, it might have done harm to man. And he says 3 reasons for that. Medical iatrogenesis. Iatros is the physician, genesis of diseases made by the physician of the hospital. And he gives chapter and verse from the most renowned journals in medicine, showing how right he is on that. So many problems, so many accidents, so many deaths produced by medications given by the doctors, procedures done by the doctors, etc. Literally quoting from famous journals. So that was one medical art. But of course, we must take it with a sense of perspective. Every medication, every procedure has a downside to it. The moral of the story, you take the advantage that it produced to the disadvantage that it has, and then decide whether it's worth doing it or not. The second thing that he says is social iatrogenesis, which I thought was very exciting because I've never heard that before. Social iatrogenesis, this professor states, is when the whole medical profession is so constructed that the general public, society at large, depends upon it for every small thing. So it goes to the doctor for a cold, it goes to the doctor for a cough, it goes to the hospital for this. Well, society should really be looking after itself. A very good point when you read the exact methodology which he has evolved to prove that. And last, he says, is cultural iatrogenesis. Cultural iatrogenesis, where the doctors feel that death has to be defeated at all costs. So right up to the end, till the last breath, you will fight. That's rubbish. You must know when the game is up. You must know when death is waiting. And when you must know that death cannot be defeated. It's important to realize that. So these are some of the major drawbacks that you have. The future of medicine is very worrying. It's very challenging. You have great vistas extending outwards. However, there are great dangers as well. Are you aware that in many parts of the world they are trying to manipulate genes of the human's body so that you're endowed with qualities which you do not have at this point in time? There is a possibility that in time to come you will evolve in, I don't know if you read some of this, I have, to my great horror. You might turn into half machine, half man, or a whole machine. The human race, a human Homo sapiens may not be what you and I have just now. You must understand that human beings have evolved over millions of years. And they have, how have they evolved? They've evolved through Charles Darwin's theory of evolution of fitness. Survival of the fittest, and perhaps a genetic drift. But what modern medicine is trying to do is so affect your genes or arrange your genes that this evolution is replaced within 100 years, 200 years, 1,000 years instead of the million years that we have taken to evolve. There is a danger in that, of course. And there is also a challenge. Advances can be there. You have artificial intelligence. Everybody knows that it has great advantages, but great people who have founded this realize the possible great disadvantages as well. Ladies and gentlemen, I think I must stop. So I thank you very much for your patience listening.